Hello, thank you for letting me share with you this clinical vignette of a patient treated with a transcallosal interhemispheric approach for resection of a colloid cyst. The patient is a 13-year-old young woman who presented with 4 months of worsening headaches. Her MRI scan revealed obstructive hydrocephalus from a 3-centimeter cystic mass centered in the septum pellucidum with an enhancing nodule extending into the left lateral ventricle. The lesion was iso-intense to the cortex on T1, T2, and FLAIR imaging. It showed an enhancing rim with contrast. It did not show diffusion restriction. The patient was positioned supine on the operating table. The head was held in a straight AP position with Mayfield pins. We used a zigzag incision in the coronal plane to allow for optimal cosmesis of her scar. The bone flap was graded to incorporate the coronal suture and cross the sagittal sinus. This is to allow for retraction of the sinus for better visualization of the anterior corpus callosum. The dura is open to flap medially, and great care must be exercised to avoid cortical vessels which may enter the dura well lateral to the sinus. The dura is trimmed to the lateral margin of the sagittal sinus for optimal visualization. The sinus may create venous lakes between the folds of the dura which extend laterally. The surgeon must maintain suspicion for their presence to allow for early detection and coagulation to prevent significant bleeding. Before retracting the sinus and falx, the underside of the dura is inspected for arachnoid granulations or other peel adhesions. After these are divided, the dural flap is used to retract the sinus and falx towards the contralateral hemisphere. Over-retraction may result in occlusion of the sinus. Tack-up sutures through the dura assist with its retraction. The initial dissection follows the firm border of the falx medially. As the dissection progresses more deeply, fixed retractors may assist with visualization. The surgeon should take great care to avoid retracting against the medial precentral gyrus. Just inferior to the falx, the cingulate sulcus and gyrus are encountered. This is often an area of particularly strong adhesions. After the adhesions are divided, the pericallosal branches of the anterior cerebral artery may be visualized. The corpus callosum appears noticeably white in contrast to the surrounding cerebral cortex. We have chosen to open the corpus callosum to the right of the ACAs, giving the tight adhesions encountered in this patient. Frequently, these vessels may be separated to allow for direct dissection between them through the corpus callosum into the leaflets of the septum pellucidum. Our dissection has led into the right lateral ventricle. We immediately encountered the septum pellucidum and cyst wall bulging laterally into the ventricle. In order to improve visualization, we fenestrated the cyst wall, which released thick mucinous fluid. This fluid was then aspirated to encourage collapse of the large cyst. We then extended our dissection of the margin between the septum pellucidum and the cyst to allow us to reflect normal tissue laterally and protect the fornices. Here the choroid plexus may be visualized leading into the right foramen of Monroe at the top center of the screen. We then sharply extended our fenestration of the cyst wall and then proceeded to further aspirate the mucinous contents. After irrigation, we were able to see the inner content of the cyst. We began to remove the cyst wall in pieces while dissecting it away from the surrounding structures and rolling it into itself. Branches of the internal cerebral vein could be seen running through the inferior portion of the cyst. We continued to remove the cyst wall using a combination of sharp and blunt dissection, as well as cavitational aspiration. The most inferior and posterior portion of the cyst was particularly adherent to the surrounding tissues. Given the risk of injury to the internal cerebral veins and bilateral fornices, we therefore chose to allow a remnant of the cyst to remain. Before closure, we insunated the ACAs to ensure optimal flow. We performed extensive hemostasis and closed the dura in a watertight fashion. Postoperative MRI showed her anterior third callosotomy with excellent debulking of her colloid cyst with a small posterior inferior remnant adherent to the velum interpositum. The patient had complete resolution of her hydrocephalus, and follow-up imaging has revealed no reoccurrence of the cyst.